now you have also a lot of cleft palate patients. And this is a case I inherit from my orthodontist and my oral surgeon from Madrid. I was not involved at all on the treatment and on the planning whatsoever. And I would like to talk about mucosa characteristics as I discussed yesterday how we were using and doing keratinized mucosa. And I would like to share this case because by itself the mucosa keratinized. So I would like to share with you this case. The patient is a pharmacist. She has a really high IQ, really smart woman. And what we did on her is distraction osteogenesis, something that you never have seen it before. And we described this case a long time ago. And today with printing the CBCTs, the surgeon can really have a good idea about where to place his screws, avoiding the roots and bringing the pieces together, bringing the segmental osteotomy forward, and bringing the canine next to a lateral incisor, a premolar on the lateral incisor. So you will see what are the problems I have to deal with. You can see all the classification of the different cleft palate, and she's the worst. She's bilateral cleft palate with involvement of the palatal aspect. Okay? This is what she looks like on the CBCT. You can see here, this is a canine. This is a lateral incisor canine. And you can see the involvement on her palate. And this is where we started. She's wearing a partial denture, a removable partial denture. And she's willing to go through this ordeal that I will explain in a minute. And she started like that, she finished like that. I finished her. And you can see that the central incisor is a lateral incisor. The lateral is a canine. Here is an implant in here. The other central incisor is a canine. The bicuspid is the first, the lateral is the first bicuspid. So you can see that even though they look like they belong to the tooth that they are corresponding, there is a lot of work that has been done before, and I would like to share with you how we did this. So what they did is was not involved in all of this. So they did first is the work of the maxillofacial surgeon. They refreshed the bone in the mesial in order to pretend to have both blocks welded. And you can see the patient is moving 1 millimeter a day. And you can see they move all the pieces to the front, and of course she has a huge class 3. So we have to open and overcome this problem. The surgeon placed the posterior implants. They are not at the same level. So you see that there are surgeons that they don't have a clue about prosthodontics. So the more you know about prosthodontics, the better surgeon you will be. And you can see here that this tooth is resorbing the palatal root of the second bicuspid, so we are losing this tooth. Here we have a pocket of 22 millimeters, and you can see here the bone loss that we got on the posterior area. So this is the hot potato I have to fix. So you can see that I have a lot of scars, no keratinized mucosa. I have overclosed vertical dimension. This is a canine. This is the first bicuspid. This is the first implant. There are 3 implants in a row here. This is a lateral incisor. This is a canine. This is an implant that is 8 millimeter palatally. It's touching the root, which is resorbing here. So I'm losing this tooth. So as a dental technician, the first thing I wanted to do is I wanted to wax myself the case to have an idea where I wanted to place the occlusal plane, how much I would need to open the vertical dimension in order to overcome the transverse problem I was having in that side. And you can see that I will need to do some root plasty in order to have the same diameters between teeth. So I did the provisional restoration myself. I opened the bite, I did the wax up of the teeth, and I also wax up the pink where I would love to have my pink. And I was showing my orthodontist friend how much he will have to incline lingually in order to minimize the transverse problem we were having on that side. So the first thing I did is I did a wax up, cut a little bit the teeth, and reline, doing an aesthetic mock-up to see if the occlusal plane was on the right place, and then decide how much tissue I have to bring down. Then I loved it. It was something that was possible for me. So what I did is I prepped the teeth. I placed some provisional abutments on the implants, and then have an idea how much I have to plump horizontally and vertically my soft tissue. So this is the first surgery. You can see that the first surgery, the papillas were cut here. Around the implants, I didn't elevate the papillas. I didn't cut my papilla in between the 2 centrals because I have no more here. And I grasped full tuberosity in between the 2 central incisors. I took advantage at that time and reduced cervically with an open flap the roots already in the first surgery, trying to have the same root diameter, especially on the line angles between the different teeth from a canine to a first premolar, to come up with some teeth that look the same. So I do a lot of root plasty. Thank God those teeth had already root canals, so it was not such a big problem. But you can see there is a full tuberosity in between 2 teeth and a full tuberosity around this implant, which is really far palatally. This is what it looks like 3 months later. You can see a lot of work to do. I still have volume to overcome, extract this tooth, place an immediate implant placement. So in the second round of connective tissue, the beauty of all these cleft palate patients is that they have had so many surgeries when you were a kid. When they were a kid, is that the palate is thick as a carpet. So you can really graft from the palate as many times as you want. You can see on the second surgery everything is flapless, is tunneled in order to maximize the soft tissue, to coronally, intentionally, all my teeth were with a flat scallop in order to bring the soft tissue, to maximize the soft tissue interproximally and buccally, and then to push it in a second part. So you can see that my hand doesn't tremble, and I take as big of a piece as possible to really overcome all the tissue that is necessary and plug all that tissue vertically and horizontally. So now I need to do a provisional restoration. I have to create an emergence profile from those implants that are too supracrestal. They are not deep enough. So that's why my effort was to create as much tissue vertically to the implant head. And then I went to the office and asked, showed my technician Yoshi how much pressure I want on each implant in order to push the tissue. So this is the provisional that we will be placing just to be able to push the tissue and overcome with a nice result. Usually when we do a provisional restoration of these characteristics, I make sure I have done a verification jig before, and so I know that my provisional is going to fit, which is sometimes if you don't do this extra step, a big problem. The other thing that I ask my technician is that I don't want any contact between my provisional and the last teeth, so it's an open contact. So in that way I can guarantee I have a perfect idea that this, the bridge is just fitting my implants and my crowns. And here we came up with an ideal scallop, and then I will have to place my margin underneath the soft tissue in order to meet the scallop that we have decided on the lab. So you can see that my provisional is placed in. The patient, of course, has been anesthetized. And then you can see an open bite. I am checking with my floss that I don't have contacts on the distal aspect of my crown. And the most important is to have an idea how deep my finishing line has to go underneath the soft tissue in order to support that emergence profile. Okay? And this is not easy to create. We use cords in order to overcome to this result. So this is where we started. And now, after all the surgery that has been done, implant, canine on a lateral position, lateral on a central position, canine on a central position, first bicuspid on a lateral position, and an implant. So you can see that we were able, at least with the control line angles, control emergence profile, and most important, control the papilla heights in a certain level that looks pretty much decent. Okay. So you can see here the different steps we have gone through. The first periodontal surgery, the second periodontal surgery, and then the final situation before we place the final crowns. You can see here all the amount of pressure that we have created with a provisional to come up with something that has the same profile from canines, from implants into teeth all around the arch. you can see the effort here that was performed in order to surgically and prosthetically come up with line angles that have pretty much the same size in order to create an emergence profile that looks similar from one side of the midline to the other. And this is not easy to do. It's a lot of effort surgically and prosthetically, looking at roots that are totally different and that belong from other areas. So every time I do orthodontics in all patients like this one, I always splint my teeth. For me, there is nothing more frustrating on adult patients that not splinting the teeth and then having movements of the teeth, open contact points, intrusions or extrusions of the teeth. So in adult patients, I always splint the teeth in different ways, as you will be seeing also later on after the break. So you can see here, looking at the tissue, how the tissue is going to be maturing as we go along, how much we are pushing the tissues, so we are favoring the papilla growth in between these. And this is the final job, the final work. There is a pocket here, but there is no bleeding. The bone is 23 millimeters from the tip of the papilla. This is where we started. This is 1 month after I cement the case, and this is 3 years down the road. You can see how the tissue is, the tissue on top of the connective, on top of the graft is keratinizing slowly. Of course, we have been blasting all the scars she had from the maxillofacial surgery. And you can see how the tissue is becoming little by little keratinized and having a nice look of it. Okay. So you can see here, there is no bleeding, there is bonding of the bone above the apex, but this is the situation where we started, where we are, and how much we were able to bond just with segmental osteotomy and doing an extraction osteogenesis, the bonding of the both parts and the final result. It's true that when you treat this type of patient at the beginning, they don't smile. By the time that they are finished, they are confident about their teeth and they smile totally different. This is the reality of my case. You can see how we take pictures with light boxes. They are 45 degrees related to the patient's head. And this is the iPhone video showing the reality of what we did on her. So you don't need to, this is from Smileline, they came up with another prototype. You don't need to calibrate your camera. It's true that sometimes the colors are not as nice, but you can see here the canine area where we didn't have any horizontal. And can we take this out? Thank you. Okay, so We have discussed yesterday immediate implant placement, how to preserve what there is today. We're going to recreate what we have lost. We are going to show you from simple to more complex the different situations and things that you probably do that we don't do anymore. The most important for me when it comes to recreate what there was, either with bone or with soft tissue, for me, if I have enough buccolingual bone to place an implant, if I have 4 millimeters of buccolingual bone, I don't do bone grafting. I compensate the volume with connective tissue grafting. As we said yesterday, the most important or immediate implant placement is to control the buccal plate. On the adjacent implant, on the delayed implants, the most important is to control the interproximal bone, because this bone is going to support the papilla height. So the way that I do surgery is totally different from the way that I've been taught. Every time I'm going to place an implant, a single tooth implant on a delayed mode, and I have sufficient buccolingual bone, I elevate my flap partial thickness. I try to avoid as much as possible to expose my bone, because I have already 30% of resorption only by exposing the bone. So let me show you the slim concept, how we started. Let me discuss the critical thinking, the surgical approach, and the prosthetic management, the benefits, and the take-home message. The concept is rather easy, is misunderstood, is underestimated, and basically is grafting crestally where the prosthodontist needs it the most, and it's just grafting with patients' own tissue only. So we have two types of, this is something that I sold to Nobel in 2014. This October is going to be 31st of October, 10 years since we launched the book, and at the same time we launched this concept, but I've been doing this since 2006, around 2006. So I'd like to share a few videos. Basically, the more you want to bring the tissue crestal, usually we use this healing abutment that only helps for the surgeon to increase the verticality of the tissue and the volume and plump the papillas. In this way, today I don't place so much soft tissue on the buccal aspect. We make a cross, and then you can go over your healing abutment, and everything has been elevated partial thickness flap. I don't do vertical raising incisions, so that means I have to go at least 1 to 1.5 sideways in order to overcome the volume that I want to improve crestally. And what I do is I suture the connective tissue to the buccal and palatal flap. And what we want is to stabilize, like everything we do in surgery. It needs to be stable, non-movable. You can see that this healing abutment is 7 millimeter high, so we are just bumping the tissue in one shot around 6 millimeters. Okay. So this healing abutment only helps the surgeon. He stays there only 3 months because what we want is I have some music on there. So can you put it on? So it only helps the surgeon to maximize the tissue crustally. It's really simple. It allows excellent primary closure, and it's a biological approach. It's just really friendly because you take patients' own tissue, so the morbidity and the inflammation is much less than using a membrane or any xenograft material, and the predictability is just amazing. So when we are going to increase the soft tissue vertically and horizontally, 99 of the dentists that I know and surgeons, they do the wrong incision. The more you want to improve your soft tissue vertically and horizontally, the incision should be as buccal as possible. 90% place it here. So by the time that you want to close it, this flap goes up and back, so it's impossible to close it. So every time you want to increase height, your incision is more buccally displaced. The more the wider the ridge, the more you will have a back door in order to improve the height of your soft tissue. You need to be aware that the more tissue you put on the palatal aspect, the more this incision that was buccal will go palatally and will be difficult for you to suture it. So you will need more displacement of your buccal flap to really close it. So that's why the thicker tissue is on the crest, less and less tissue is placed on the buccal, because usually if you put too much on the buccal, you will see that you have a difference on a dissimilarity on the volume you are creating on your implant with respect to the adjacent tooth. So the beauty of having this slim healing abutment is acts as a bond, so the tissue won't move, and it's easier for you to come outside of your flap, taking the connective tissue, getting out, and suture. So the soft tissue is stable on the crest, and then you suture it on top of it. We only maintain this abutment 3 months. Why is that? Because if you have placed the implant deeper, because maybe you have increased the bone, the bone can grow on top of it, and if you leave it for 6 months, it would be impossible for you to remove the healing abutment. So this technique works only for 3 months. So basically, 3 months later, you take out your slim healing abutment and place a normal healing abutment, and then it's the prosthodontist who starts pushing the tissue around. And this is a healing abutment that is designed to be done one-stage surgery. So we have many cases. You see this one. What is important? Many dentists that come to our courses, they calculate a soft tissue that is too narrow. And what we want is that the tissue fits the mesiodistal aspect of the tooth you are replacing. So this way you are able to support the interproximal papilla one shot. So you can see that if you are too short and not touching the adjacent tooth, you won't support the papilla in the same way. The more you place your incision on the center, and the more tissue you put at the back, the more difficult it will be to suture it crustally. Okay? So then can go from this healing abutment and have something, an intermediate healing abutment. You can go a wider healing abutment. You can make a custom healing abutment, or you can jump directly to a final zirconia abutment. At that time, 10 years ago, we didn't have the angulation screws that we have today. So pretty much everything was cement retained rather than screw retained. Today, everything that I do is screw retained, especially because of access to the implant head and the preimplantitis. So you know that I will explain how we create the emergence, how we modify this tissue as we go along. And here, when you have patients that have bleaching, it's difficult to evaluate the value. So this is a trick we use a lot. We place Vaseline on top of the teeth, so we keep them moist. So this moisture stays longer, and we have a better vision of the situation and decide if the value is correct. You can see the contact points are from there. This is the first plate from Yoshi. As you can see it here, really nice blending of the restoration. This is when we finished. You can see how much we are sticking out the restoration in order to confine the tissue and allow the tissue to be kind of sequestered in this place. This is the initial situation. You can see we usually place the bigger amount of tissue depending upon the height of the papilla we are looking for. This is about a month later, this is 2015. We wrote an article on QDT about the slim concept, and you can see all the different steps, all the prosthetic phases that will go in a moment, and how to deal with it. This is 4 years down the road. The teeth has moved. If you look at it, the teeth has extruded. The contact point is not there anymore. She had some foot impaction. So what we did is we placed a little wedge and did a new composite. This is 4 years down the road. You can see that even though the tooth is splinted from central incisor to the canine, we still have some movement of the tooth. This is the iPhone video, several years down the road. So how this started? I was trained as a periodontist at University of Washington, and over there we were using already concave healing abutments. And we were not using straight conventional abutments because what we wanted was to improve the thickness of the soft tissue and really be able to create an abundance of soft tissue and be able in this way to hide better the connection with our implants. So you can see that with this abutment, I always saw that the tissue was gliding. It was never staying level to where I placed it. So I thought that making some holes in the healing abutment will favor the suturing in a better way. But actually, this is not easy, and I will show you why. But this guy was beating all of them. As soon as I took the platform off, the tissue even grew on top of it and was disappearing. And then I saw that the more I was resting on top of my healing abutment, the less cracking of my provisional. And I decided to place a prosthetic head. And those are all prototypes that were done by a patient of mine who is an engineer. So, if you look at it, this is an agenesis of the lateral incisor, and I thought at the beginning that the wider the platform on the top, the more I will protect the soft tissue, but actually is the wrong answer, because it's really difficult to have a primary closure. You have too tight of a suturing technique on the crest, and usually you lose height even though we have the volume, and we came up with something that looks nice. So those are pictures from the book. We had two versions of this healing abutment. One was a hole. The problem with the hole is that the pitch of the threads of the healing abutment doesn't correspond to the pitch of your implant. So this could end up on the mesial aspect, difficult to suture. You have to suture with a 6-0 suture. It's not for every dentist. I had another one that was just a notch, so you could go through the notch and pinch your suture in an easier way, but none of those really show the difference. Sometimes when it was interproximally, it was difficult to suture it, but the results were consistent as far as how much tissue you were able to graft crestally. It's true that the flap over it was more demanding, but the results were consistent every time. We wanted to have a perfect adaptation of your flaps, so we could see no incision whatsoever. This is the result several years after, where you can see that the papilla height is pretty much level with the rest of the papillas. But this guy was just amazing. We were having all of those were done by myself, and I will share with you after the break how I have been modifying them just with lathe and carbide burrs, how we were reducing, and this concept can be adapted to any implant market. So you can see here that if a surgeon sees this, the first thing he's gonna see on this cleft type of recession, he will do bone grafting. For me, if I have enough conlingual plate of 4 millimeters to place a 3.5 millimeter implant, I will compensate the volume with a rich lab connective tissue. Really simple. You can see that the healing abutment usually was buried, and then we were jumping into a wider, the narrow was the healing impression coping, and at that time I have my tie base on this novel active implant that was constructed by the same patient, and in this way I had better less problems with fracture of my abutments and finished case. Sorry. This is when I used to have my Instagram that was hacked, and you can see here the picture of the same implant 11 years down the road. This is a removable partial denture on this patient who is 82 years old, and with the advent of zirconia, full contour zirconia teeth, we do removables with zirconia teeth, which he loves, and we did some composite, a hybrid crown. Instead of extruding and make his life more miserable, we did the crown with some composite and doing some guided clasps less removable, and he was happy camper. So you can see that we put it on the lathe, and then we grind it. The way that we do it is, as one goes forward, the other one goes backwards, and you can reduce this way any healing abutment. So let me show you this case that I showed you yesterday. Of course, it's impossible to do immediate implant placement. There is no bone to anchor the implant. And maybe when you have this type of resorption, the worst is to lose the palatal bone. Why? Because the more you lose the palatal bone, or the less tissue you have on the palate, the more difficult it is to create volume of the button. So I like to use the Stimmelmeyer technique, which is epithelialized, de-epithelialized connective tissue graft, which is saddled, sutured to the socket. I don't do it the way that he does it, because you denude the palate, and the patient thinks about you and your family for 30 days, because it's really painful. So I don't do it that way, and the best provisional ever is to use the same patient's tooth. It really is the best provisional for me. I only do either composite. I don't do any type of Maryland bridge or rochette. I do it in composite, or if I have the same tooth of the patient, I cut it and I bond it to the adjacent teeth. So it was a really stormy healing. What you should know is that every time you use the Stimmelmeyer technique and you graft with epithelialized connective tissue, in a great percentage of them, you will have a defect in the center. Now, usually I wait 8 months before I go ahead and place my implant. And usually I do take a line where is the buccal plate of the adjacent tooth, number 21, and have an idea if what I'm seeing is a bone defect vertically, or it can be easily compensated with soft tissue. You can see here that is a soft tissue problem. It's rather easy. What I like about grafting same day is that the quality of the bone is much better than if I don't graft crestally, because this tissue is thicker, is coming from another part of the mouth. It will withstand any pressure that I will create placing my tissue crestally. So it's a good way of finishing the case. You can see I have enough bone to really place 3.5 implants, which is my best option when it goes to delayed implant placement. So I have already discussed where we place the incision. This is how it looks like 1 week after. And the less titanium, the more space you have to increase your soft tissue. So this is about 3 months. 3 months later, what I do is I take an impression. I already discussed yesterday, but I will get back to the issue of the depth of the implants on grafted sites. I place my implant at least 2 to 2.5 millimeters below bone, because under function you will see always a bone loss, a craterization around the implant. Quality of the bone is always bad at the crest, no matter what you do. So you can see here we have volume, and now it's a matter of trying to pushing it, and you have different ways of doing it. You can anesthetize, as I told you before. I leave my healing abutment only 3 months. This healing abutment only helps the surgeon. It doesn't help the prosthodontist. So in order to remove this healing abutment, you have to pull it. It's like champagne for everybody. Okay. It stays there, it doesn't come out. You will see it in the videos in a moment. And then you can jump from this slim healing abutment, surgical healing abutment, to a prosthetic one. You can use customize, wider, it depends what you prefer, or your prosthodontist prefer. And then you use an impression coping that has the same diameter than your healing abutment. And then you can go through a provisional abutment and to a final zirconia abutment, either screw retain or cement retain. What I like to do is I'm a dental technician too, so I'm quite lazy. I want the results fast, so I go from here to here and here to the final zirconia abutment with a provisional crown and finish the case. So, but you can, better is to go little by little. You need to understand that if you graft with tuberosity, connective tissue graft, there is not such a thing than necrosis of the soft tissue. Actually, this is the first time that the patient will be hurt. So usually we use corticosteroids and painkillers because it's the first time that it's painful for the patient. You need to understand how the soft tissue behaves. The wider the healing abutment, the more the tissue will recede towards the apex and towards the center. So you will see your finishing line sticking out of the soft tissue. So don't worry. Okay? We'll show you how we fabricate these abutments in the lab, and you will see within a month, in 3 months, the tissue will follow the anatomy of what you have provided. The idea here is that the technician has to create a root, copying the root of the adjacent tooth, so we don't have any subjective idea about what it should look like, but an objective way of fabricating an abutment. So you can be jumping steps. It depends upon how much you are acquainted with the lab procedure and the prosthetics. You can see that the depth here, my implant is way too crestal, it's not deep enough, and that they have a craterization because that weak bone that I grafted. So you can see this is a beautiful shot about what I was discussing. The tissue will recede vertically and horizontally towards the center. And you will see, you have to rely on it, you will see how the tissue will creep back. It takes around 3 months to see that and to have a perfect. So let's go to the surgery again. So this is the tooth. How far buccal? Well, I have to respect the papillas. I will never go here because then the flap will be wider than the mesiodistal space. So always to respect the papillas, and everything is partial thickness. What I want to see is a really thick, dense crestal soft tissue. I don't do vertical releasing incision, only when I do GBR, and usually I do only one releasing incision, not two. The more you do releasing incision, the more you are decreasing the blood supply, the more you are creating scars. It depends how you do it. So this partial thickness flap, my connective tissue gets blood supply from the periosteum. This is freehand. At that time, all cases, you can see the mobility of the flap. This is the 7 millimeter healing abutment. Not all the systems have such a high healing abutment, which for me is essential. For example, Straumann, the highest is 5 millimeters, which is a little short for me. Usually I place way too much soft tissue on the buccal aspect. You will see that this will create a problem later on. So I always make, you can see at the beginning you try to fill with soft tissue the buccal defect, the buccal bone defect. You don't need that. If you only graft crestal, it's more than enough. By the time that you are pushing the tissue, and I will show you some cases later on, when you have limited amount of soft tissue to graft from, you will see a great result. Usually I use biologic agents like amelogenin, which is endogain, and this is injected when everything is being sutured. Okay, so in this way you don't waste material, and I bond the tooth to the adjacent teeth with composite. Usually I rest on top of the healing abutment, especially if I have enough stability of the implant, of course. You need to understand that it's a totally different concept than in delayed and immediate. On immediate, you have a surface, 100% of contact surface with your implant. So this is 3 months later. We're going to remove the healing abutment. Please watch. It's moving. But the healing abutment, you have to pull it out. Okay? It doesn't come out. Okay? And then you replace the narrower healing impression copy you have. You take your impression. And normally, after the impression, you should be using or placing a healing abutment with the same diameter of your impression copy. In this case, I was lazy, so I placed it the same. So I was faster, I didn't have to realign my provisional. And then in the lab, what we're going to do, I'm going to show you how we have to bond back again the tooth. So the patient is wearing something while we are doing the provisional restoration. So today you can use screw retain provisional restoration. At that time we used to do a full contour wax up. From that full contour wax up we were creating an emergence profile. And from that emergence profile, we were creating a divergent cratering from the implant head all the way up to this ideal finishing line. So everything you are removing with the burr, you are creating a pressure with your abutment in the mouth. And this can be really painful for the patient. Creates and exerts a lot of pressure on the tissue. But of course, I'm not going to create the same pressure, and the pressure is dependent upon the type of connective tissue I have used. if I have used connective tissue from the palate, I wouldn't dare to place so much pressure. Why? Because I can create too much over recession. That tissue is not strong enough. They don't have the same collagen type 1 that you can get from the tuberosity. So I will take it with more caution. I will go slowly, and I will discuss that after the break in some other cases. Sorry. You can see here, now we're going to do our composite, simple composite, dentin and incisal halo, nothing really difficult. I'm going to polish. If you look at my book, 90% of the single tooth implants, the adjacent tooth has a composite. To improve the contact point, this is the final zirconia abutment with the tail base. We disinfected with glutaraldehyde 10% during 10 minutes. Second time is coming really easy. You really wash it with water, place it back. Simple. With a plier. You can see it looks like you haven't done too much. Basically, we ask the patient to come a month later. And within a month, you already see how the papillae are coming back. What is important is to have good surface contact between teeth and the tooth. So I need good interproximal contact to guarantee that this papilla will come down to the space allocated. You cannot pretend to have a perfect fit. We take it out and we add acrylic if necessary. There is no secret in prosthodontics, and it's polished, and more polished. And then you will see the tissue is coming back. Take out the abutment, you go straight with your final abutment from screw retained provisional, doesn't matter. Can be applied to any type of restoration. And you can see good contact point. The patient leaves, comes back 1 month later to take final impression. Today he's a doctor, he's a traumatologist. He's in Madrid. You can see I want to bring my margin on the buccal a little bit deeper. You can see how the tissue is coming back little by little. We take an impression, and usually I don't wait as much as I used to. So within a month, I start. After 3 months of healing, I start doing my provisional, and 1 month later, I start taking my impression for the final crown. So the sooner you provide your provisional, the better. In this case, I have the brothers, the Rutten brothers from Belgium coming to San Sebastian because they were, this case was going to be the first one that we were filming to show all the steps and basically how the European technician bakes the full contour bake and then they try it. So I have my own lab at home. So we bake it every time you start removing things, the soft tissue lose his shape, is normal. And then being myself a dental technician, I tell him, listen, you don't have too much chroma, I want more pressure, the contact point is concave, I want you to push a little bit more on the buccal aspect. I need more contact points in the proximally. I want more of the surface. I need to push more in the proximally and buccally. So he makes on a second bake. He tries to make all the indications. Now you are way too dentinous, too much chroma. I like the contact point. I will add some composite on adjacent tooth. You put too much tissue. So I start modifying everything he has done. I need more contact point on the distal with and then on the glaze he tries to compensate everything, add contacts, and then modifying the final crown to finish the case. Once I have the final crown the way that I like it, I modify the contour of my tooth. It's way too concave. I want to have, I want to push my papilla. I want to have a contact surface from the point, and I make one contact after the other. Okay, these simple cases. I create an emergence. I polish. Use discs. Once I have done one side, then I go to the other side. You can see I open the space. How much do I open? Pretty much level to the contralateral papilla. Okay? So I would love those papillas to fall instead of closing the spaces and opening the black spaces. Many technicians in the world, as soon as they see a black space, they close it. Here is totally the opposite. You open it because we have grafted interproximal. So if you have ever used final abutment as a professional, I take it out. I check if there is no cement remnant excess bonded to the tissue. I torque it down. Today we don't use Teflon. We use, as I showed you before, the silver plug, which is a polymer that is embedded with silver. So what creates is less bacteria accumulation. This the day of the finished case. Of course, we desiccate the tooth and the color doesn't look nice. And then he's coming back a month later. And we're asking him how happy he is. And this is how the tissue is coming back little by little. Even though we have a distal rotation, the tissue is coming down, and it's a matter of time the tissue will come down proximally. Be careful every time that you place a single tooth implant. As I told you yesterday, you have to check the rest of the contact points. And usually we close the contact points if there is no contact, because if not, the teeth are going to be drifted. They're going to drift. Here we close the space. And this is how I started, how I finish. It's not ideal. Time we do the rest. You can see that the volume of the papilla is shorter than when we started. But this is 7 years down the road. You can see I put too much soft tissue. You remember I was telling you I put way too much tissue on the buccal, but you can see how the tissue is coming down and is filling on the buccal. Okay? You can see the leveling of the papilla. So let me jump a little bit forward. I have 10 minutes. Okay, so I have how much do I have? 5 minutes, okay. So I have 5 minutes. Let me show you the last thing. 2019, I used the Thai Ultra as an anodized collar, and we see great results. And basically, nobody can tell you have the implant. You can see we use the same concept with crestal connective tissue. You can see here the flap management, how we modify the soft tissue based on the mesodistal space, and then we jump to a normal hitting a back band and finalize the case. So we have many cases, and I would like to share a complex one, especially when you have kids that had an apicoectomy, no buccal bone. Today I would have done an immediate implant placement, as I showed you yesterday, but at that time we were not doing that. And you can see we have a fistula. She's 16 years old, she's in pain, so we did socket preservation technique. Usually I don't use this technique, it's really painful. Today what I do is I de-epithelialize the distal and mesial aspect, and I take only, this is about perforation of 1 millimeter, and then I take all the lamina propria from front to back. This is really painful for the patients. So you can see how we do it today. I go over 1 millimeter each side. I de-epithelialize the distal and the mesial. The palatal is always shorter than the buccal. And the incision is just 1 millimeter in depth, the center. So this is the epithelialized tissue. As I showed you yesterday, I first de-epithelialize with my burr, and then I cut to guarantee that there is no epithelium left on my corners. Then I suture, then I place my sponges, my collagen sponges, and then what I do is I place my cyanoacrylate on top and remove it within 15 days. Okay? The idea is this extension of 1 millimeter go below the papillas, so you will maintain in a better way the soft tissue. Is another case. Going back to the case I started, you can see all the fractures, the apicoectomy, how bad this teeth was, and we never elevate the flap. It's a flapless procedure, and as I showed you yesterday, we make some vertical vista, small openings just to tag our membrane and graft the site. So this is where we started. This is 5 years down the road. We use the same tooth as a provisional restoration. And what I want is just to pay attention. We didn't have enough soft tissue, so we are just missing a lot of papilla. This is 2009 when she's 16 years old. This is day 0 of the socket preservation. This is 5 years down the road. You can see how much more resorption we got, but we still have space for placing my implant. As soon as I see any vertical movement on my cephalometric tracing, I wait another year. So we waited on her until 23 years old to place her implant. And then I do these extensions when I have short papillas. And we only grafted crestally. Okay? So we don't go above if there is a thin biotype, phenotype, like in this case, we just grafted crestally and on the adjacent teeth in order to control the papilla volume. You can see when I place the provisional restoration, you can see the convexity compared to a concavity compared to this. This is a problem. Thanks God she doesn't show it, but papilla-wise, we have a nice papilla coming back. This implant is a little bit deeper, so we have a nice bone response crustally. This is the iPhone video. You can see being in concave and have a different emergence profile on the tooth. It's a grayish appearance. But as the tissue is maturing, you will see how the tissue is growing. This is when I place my provisional, how much I'm pushing. It looks like there is not enough volume to overcome the nice emergence profile of the tooth. But as we are going forward, I always use 3mm titanium abutment. This is 1 month, and this is 3 months later. You can see how the tissue is maturing, is growing, it's stabilized. You can see the long papillas, level papillas all around, and then we finish the case. So you can see that you don't need to place as much tissue buccal as you might think. Having it crustally is just the most important part. Everything is splinted. This 2009 against 2016. Look at my provisional model, and this is an alternate of the final work several years down the road. You can see the height of the papillas are perfect, and the iPhone video several years down the road. Okay, so with that I will finish there, so you can continue with your session. So thank you very much for your attention.